We'll give it another minute as people are logging on. This is our annual What's New in ART update, and we're very grateful to have Dr. Brian Wood, who many of you know. He's quite famous as the medical director of HIV Project ECHO for the Mountain West region. He's associate professor of medicine, soon to be professor of medicine at UW as well. And he's just come off a very busy 2 weeks on the inpatient service. So really grateful to have him here and tell us what's new. So thank you, Brian.
Thank you, Trisha. Thanks everyone for having me back. Victor, Chris, thanks for all the behind the scenes work to make this happen. And welcome everyone. My task is to give you an update in what's new. I had the honor of doing this last year as well, so I'll focus on updates, trends, what's in the pipeline for the future. And I like to get input from you. I like to hear from you. So I have a couple of poll questions and we'll ask you your opinions on a few things as well. I don't have any conflicts. I will discuss investigational treatments. I'm really going to focus on updates in treatment for adults with HIV, including some of the newly approved agents. Again, what's coming in the pipeline, what we are seeing a lot of in terms of new studies of HIV treatment, and which direction the field is going. And I'll ask you which direction you think the field of HIV treatment should go. So to start with, I was reflecting on new FDA approvals and indications over the last 3 years or so. Here's what we've seen as a review: fostemsavir, the GP120 attachment inhibitor, a twice daily oral drug, approved really for heavily treatment experienced individuals with few remaining ARV options. I have a couple people on my panel receiving this drug, but not widespread use. The twice daily dosing is limiting for some, but it is a well-tolerated, effective new class of ARV. So it is very effective for individuals who need it. And then, as you know, we have entered this era of long-acting antiretroviral therapy, the first ever long-acting agents, which we were so excited about, and providers, patients were so looking forward to, but has been so limited by the barriers getting it to people who want it. And we'll talk more about that. But as a review, cabotegravir-rilpivirine, the long-acting integrase inhibitor and an RTI combination, was approved in 2021 for every 1 month dosing, and the FDA indication was expanded to give an option for every 2 months in 2022. I think it's interesting that in this country we have the option of every 1 versus every 2 months. Many countries around the world that have approved this agent have only allowed every 2 month dosing. So we are unique in that we have options to sort through for people who qualify for and want this agent. The label is also updated to make the oral lead-in optional, and the FDA indication is still virologically suppressed individuals with no resistance to the components. And then I would add no hepatitis B unless you add effective oral hepatitis B therapy. And then lenacapavir, approved since we talked last year, the capsid inhibitor, which I'll abbreviate as CI, and we'll talk more about that, offers subcutaneous dosing every 6 months, again, indicated for heavily treatment experienced individuals with HIV with few remaining options. We'll come back to this. Use of this agent has been pretty severely limited by cost and access issues, but we will talk more. But that's the last 3 years. If you compare that to the 3 years prior, we saw a lot of new, potent, highly effective, high barrier resistance, once daily oral agents. So things have shifted a bit, which I think is interesting. And then if we look at the research happening right now, the studies we're seeing and what's coming, let me focus on a few things, and these are some of the topics we'll be coming back to. So a lot of research now into the potential expanded indications or uses for already approved agents. The IM cabotegravir-rilpivirine in the setting of viremia and barriers to taking oral pills has been a hot topic. We've talked about it before, and I'll give you some updates. Subcutaneous lenacapavir is being studied as part of initial ART. There's a lot of research into new models for delivery of long-acting agents, and a lot of study and research into the potential cardiometabolic benefits of specific antiretroviral agents or ART switches. And we'll come back to that a bit, but we're seeing a lot of that. Now, I find it fascinating to look at the new combination tablets being developed. So lenacapavir bictegravir as an oral daily pill and doravirine islatravir as an oral daily pill have been called the last oral daily pills in the pipeline. These really are the oral combination tablets that are in development. Maybe we will see more, but right now that is what's being studied as oral daily therapy. There are these other oral weekly options like lenacapavir, islatravir, which is moving forward, and I'll talk more about that. And this combination of islatravir and a long-acting novel NNRTI, ulanavirine, which sort of suffered from too high a dose of islatravir in the study, and that development has paused, but I think we will hear more about it in the future. So potent oral daily or weekly combination tablets are coming, but the list is not long. And then there's a lot of study into new long-acting agents, broadly neutralizing antibodies on their own or in combination, dual affinity retargeting proteins and other immunotherapies, a maturation inhibitor which blocks GAG from being cleaved, blocks a late step in the process similar to protease inhibitors. We saw phase 1 and 2 studies of a daily oral version that is not moving forward, but there are long-acting versions in earlier study. And then some really interesting development of long-acting nanoparticle forms of existing ARVs, including really interesting research by colleagues here at UW. These things I think are still trying to find their seat at the table and their place in our armamentarium, but there are some interesting things, and I'll talk more about it. And I'll really focus on things going into phase 2 or beyond. And then again, I'd love to hear your opinion. What of this do you think really should be our priority and our biggest investment for the future of HIV treatment? So I'll put that question to you now to think about, and I'll ask you more formally towards the end. But let's dive into a couple of these topics. Let's first discuss potential expanded indications and model for delivering the IM long-acting cabotegravir rilpivirine. And I'll start by the poll. Chris, if you don't mind launching this, I'd just like to hear from everybody. I know it's early. If you're in a place where you can answer, please do. For your patients or clients who expressed an interest in this option, what has been the most frequent reason for not ending up prescribing it or accessing it? What has been the biggest reason, barrier or otherwise? Cost or coverage or logistical issues, clinical factors, maybe you look back and there's drug resistance that prevents it, detectable viral load and we're not sure what to do with that, hepatitis B infection, other, or simply preference. I've had several, probably more than several individuals who've expressed interest in this option when they talk about coming to clinic every 1 or 2 months and the regular injections versus an oral pill daily and visits every 6 months. Some people decide it's not actually the right option for them. So Chris, why don't we give that 5 more seconds and then display. Okay, actually we displayed, perfect. Share the results. Hopefully everyone's seeing that. So 65% cost coverage issues, logistical barriers, absolutely. It is really tough to access these drugs, which is a big issue. Clinical factors and then preference, actually preference being number 2 there. Perfect, thanks everybody for weighing in. I think that's been similar to my experience as well. I've certainly talked with people about this option. Often individuals hear about the long-acting option, it sounds so great, and then we get down into the nitty-gritty, it is just plain hard to access. And that is a challenge, and I think prevents this drug combination from being as big a game changer for us as it could be. Now, what does it take to access long-acting ART? The answer is a lot. It takes a lot of work. If you talk with Trish and Jihan and G and Bob and others in Madison Clinic, it takes a lot of work. This is a diagram from a nice review of the barriers and potential solutions to accessing IM cabotegravir rilpivirine from clinics who are involved in getting this for patients. And I won't go through this, I'll encourage you to read it. But some of the barriers include adherence to injection appointments, injection tolerability, the injection site pain can be pretty limiting, and then a lot on the workflow. Like it really takes a lot of planning for workflow and logistics. There's a recommendation to increase staff, to do a lot of staff training. It really takes a lot of hours and work and legwork to access these. And then of course, until the cost is competitive with oral ART, including generic ART options, which are out there now, the dissemination of this option is going to be very limited. I'll leave it at that. I'll also encourage you to look at a talk on our ECHO YouTube channel from Ji Lee. It's a really excellent talk about implementing long-acting ART. But again, there are barriers. It takes a lot of work, and we really need effective solutions to get this to more people who need it. Let me turn to an update on prescribing long-acting rilpivirine for individuals with detectable viremia or a history of barriers to adherence or missed oral ART doses. This is an update of what I have found in the literature or from recent conferences. The Ward 86 study we've talked about, and I'll go into a bit more detail, give you an update. The publication from Monica Gandhi in Annals of Internal Medicine happened since we talked last. So I'll give you a bit more detail on this, but I think you know it was a single center, single arm, open label study at an urban academic safety net clinic that serves publicly insured patients, and they enrolled individuals with or without viral suppression. And the key data, again, I'll tell you more about the virologic failures, but the key data are those individuals who started rilpivirine. Everyone started with monthly dosing. Those individuals who started with a suppressed viral load maintained suppression 100%. Those individuals who started with a detectable viral load generally did well, with a couple of exceptions. The overall virologic failures were infrequent, occurred early within the first 6 months, and gave a virologic failure rate of 1.5%, which is quite similar to the virologic failure rate in the large registration randomized controlled trials. We'll go into a bit more detail about the failures. The other data, I won't talk about in as much detail, but you have it here if you want to dig into it. Just last month at ID Week, we saw an update from the OPERA cohort, specifically on rilpivirine for those individuals who had a detectable viral load. You can see the number here with a viral load above 50 or a viral load above 200, and the median viral load, which overall was relatively low. And you can see that 82% achieved any viral load below 50, 75% viral load below 50 at study end. There were 7 virologic failures, although 3 of those individuals actually were able to continue on or restart rilpivirine and do well. So really, it was 4 virologic failures leading to a change of therapy, and overall a relatively similar virologic failure rate to in the Ward 86 study. JABS is a study from Australia that was presented at IAS over the summer. I hesitate to include this here because everyone was suppressed, but they describe administering rilpivirine for individuals with historic adherence challenges to oral ART, a lot of complex medical conditions and social and economic vulnerability, and those individuals did quite well overall. There were no virologic failures. We previously talked about the compassionate use paper, which is individuals with really significant medical conditions and challenges with oral ART adherence. And I'll refer you to that paper if you want to see more. And then there have been several case studies and case series, which I think give some really interesting anecdotes about rilpivirine for cases where it is really needed and oral ART is just not working, including in people with very advanced HIV. This case series of 3 individuals was 3 individuals with who had acquired HIV perinatally, had a long history of ART, various ART regimens, resistance, a lot of challenges. One individual had a viral load over 10 million and received rilpivirine regularly in clinic, plus home infusions of IV ibalizumab, the post-attachment inhibitor, every 2 weeks, and achieved their lowest viral load in many years. So a lot of interesting lessons learned and a lot of questions about indications for rilpivirine in the setting of a detectable viral load. Turning back to the UCSF Ward 86 study, this is the update since last year from the publication in July. Again, of those individuals who started with a viral load below 30, 100% maintain that viral load. You can see the median number of injections, and you can see that 5 chose to resume oral ART, and the reasons were primarily injection site reactions, especially pain, or difficulties adhering to the clinic visits, which again were every 1 month at the start, and then for some individuals who maintained a suppressed viral load, there was a transition to every 2-month injections. Then probably the most interesting and most talked about part of the study, of 57 individuals who started with a baseline viral load above 30, after a median number of injections of 7, there were 2 early virologic failures. I'll show you those on the next slide, plus 1 participant with a viral load that was low, 182, but after 5 injections. And so the investigators added lenacapavir to the cabrilpivirine, which I think is an interesting strategy. I don't know of a registration trial looking at this combination of every 6-month sub-Q lenacapavir with IM cabrilpivirine, but I think it does have potential, and I think we will see more demonstration project data for that combination, especially if individuals have some minor integrase or NNRTI resistance and would really benefit from this therapy, but you're worried about the efficacy. I think that has potential. The investigators also described 1 participant who suppressed their viral load, but then later rebounded and resuppressed on oral darunavir-CoV-TAF FTC. And they note that this individual had a BMI above 30, which is definitely not a contraindication to this therapy, but does necessitate use of a longer needle to make sure that the drug is injected intramuscularly. And they note that at least one of the injections was inadvertently given without the longer needle, and drug levels may have been lower than the goal or than the effective range. So that may have contributed. Now, the 2 virologic failures in this paper, I'll show you because I think there are some important lessons. So for the first individual, there was a decrease in viral load of less than 2 log at the first maintenance injection. So remember, there's a loading dose and then there are maintenance injections every month. So basically at injection number 2, there was less than a 2 log decrease in viral load. So genotype was done. There was a new NNRTI resistance mutation. The long-acting ART was discontinued, and then a repeat genotype later actually showed another NNRTI mutation. The risk factors described included a baseline rilpivirine mutation as well as rifabutin use 2 weeks before the long-acting agents were started. For the other participant with virologic failure despite on-time injections, again, there was a decrease in viral load of less than 2 logs at basically injection number 2. Interestingly, at injection number 3, the viral load was suppressed, but a genotype that had been sent at this point at injection number 2 showed new NNRTI and integrase resistance, so the long-acting injectables were stopped. And this individual had a baseline minor integrase mutation before starting the long-acting injectables. So the lesson here, and what actually led to a change in protocol for the Ward 86 researchers, was that minor integrase or minor cabotegravir or rilpivirine resistance may portend virologic failure. And so they changed their protocol to exclude individuals with such mutations. So I'd be very hesitant to prescribe this option for individuals with any rilpivirine or cabotegravir resistance, even minor. The other lesson is that if an individual has a viral load decrease of less than 2 log at injection number 2, I would monitor very closely and consider genotype to look for resistance. Again, most of the virologic failures on this therapy in this study and in the phase 3 registration trials occurred relatively early, within the first few months of making the transition to the IM options. Now, another thing that came out this year, which I want you to be aware of, is a modeling study that looked at the success based on viral suppression and survival of the long-acting injectables for individuals with detectable viral loads. So really, this is a simulation of participants similar to the non-suppressed cohort in the Ward 86 study. That's what was used as the basis. So not basing this on a ton of data, but that was used as the for the simulation in the model. So the mean CD4 count was 150. Standard deviation of 75, and this was a comparison of individuals starting IM cabrilpivirine with a detectable viral load, receiving an integrase inhibitor-based ART regimen, an oral regimen, an integrase inhibitor-based regimen with wraparound services, which was defined as case management, nursing and community health outreach support, or the long-acting cabotegravir rilpivirine with wraparound services. You can see here the projected viral suppression actually was best with the long-acting therapy and wraparound services, though very similar to the integrase inhibitor-based oral ART with wraparound services. And you can see here the life expectancy overall was relatively similar. Again, it's a modeling study. It's not based on a ton of data, but I think it is interesting, and I'll encourage you to take a look at the details if you're interested in this topic. The other thing this really emphasizes to me is the importance of the wraparound services, and we're very lucky at places like Madison Clinic where that is standard, but that is not true in every clinic or every setting around the country. So in terms of prescribing long-acting injectable cabotegravir rilpivirine in the setting of a detectable viral load or missed doses of oral ART, both the HHS guidelines and IAS USA guidelines still recommend against it, but we will see more data from other demonstration projects. There is the ongoing clinical trial called Latitude, which is still enrolling, and I understand there is a new study coming potentially this spring to the UW Positive Research team. If there's any detail you can offer on that, please do. And if not, then to everyone, stay tuned to hear more about that new study of the long-acting agents in the setting of a detectable viral load or missed doses of oral ART. The other thing we saw this year, since I talked to you last, in terms of research around IM rilpivirine that I think is interesting and worth noting, is publication of this study called SOLAR. And I think the study is worth noting because it's a comparison of IM rilpivirine every 2 months compared to what really is our, I would say, current standard go-to daily oral regimen, BIC/TAF FTC. So for this trial, investigators enrolled adults with HIV who were taking BIC/TAF FTC as their first or second regimen, had no history of non-integrase inhibitor-based ART, no known or suspected resistance to the study drugs, and a suppressed viral load for at least 6 months. Individuals were randomized to either continue their daily oral BIC/TAF FTC or transition to IM rilpivirine every 2 months with an option of either doing the oral lead-in, a month of daily oral rilpivirine to document tolerability, or skipping the oral lead-in in what's called a direct-to-inject strategy, both of which are very reasonable and supported by the FDA and by research. And you can see here how many individuals opted for the oral lead-in or did not. And I think there are some important lessons to note here. The overall rate of virologic suppression in a modified intention to treat analysis was quite similar. And this is at month 11 of IM rilpivirine for those who did a month of oral lead-in, or month 12 for those who skipped it. So that's why it's at a month 11 or 12 of the injectable therapy. There were 2 confirmed virologic failures in the IM rilpivirine arm compared to 0 in the BIC/TAF FTC arm. The virologic failure cases in the IM rilpivirine arm had received on-time injections, did have good drug levels, but both had emergent integrase inhibitor and NNRTI resistance mutations. One had a CAB resistance-associated mutation at baseline, which may have been a risk factor for virologic failure, and both resuppressed on darunavir-CoV-TAF FTC. So there is a low rate of virologic failure on IM rilpivirine despite on-time injections and good drug levels. That rate is probably less than 1% to 2%, depends on the study you look at, but it can happen. It can lead to emergent resistance. And if it happens, the most frequent oral ART to prescribe is boosted darunavir with TAF FTC. These are things I do counsel people about when talking about this long-acting option. The other outcome of SOLAR that we saw at CROI was a look at the cardiometabolic changes over time, comparing IM rilpivirine every 2 months to continuing BIC/TAF FTC. Again, this is a hot topic subject of a lot of research. What happens with a switch of ART? What happens to weight, BMI, or I think more importantly, other changes that have been associated with metabolic syndrome and cardiovascular outcomes, like waist and hip circumference, waist to hip ratio, waist to height ratio, insulin resistance, abdominal obesity, or metabolic syndrome. The punchline here is that there was no difference over time in changes of any of these parameters looking at continuation of daily oral Bictaf FDC for individuals who were suppressed and had good adherence on that regimen compared to a switch to every 2-month IM rilpivirine. So I think that we cannot counsel people that switching to IM rilpivirine will lead to weight loss or improvement in any of these parameters. That is not an indication to switch. If you look at the details, people in the switch arm of this study had a lot of different experiences. Some gained weight, some lost weight, a lot stayed stable. And over time, there really was no difference comparing the two arms. It was thought that stoppage of TAF with the switch might lead to improvements in some of these metabolic outcomes, and that really did not happen. And this is one of quite a few studies now that have found that stopping TAF does not lead to improvements in these markers. And I think that that's something I hear commonly, is that stopping TAF will lead to weight loss. And I just don't think that the data supports that. Switching TAF to TDF leads to weight loss because TDF suppresses weight in some way that we don't fully understand. But there's quite a bit of data now that stopping TAF does not lead to the same effect. So that was an interesting outcome of SOLAR that we saw at CROI. Another thing we saw just last month at ID Week was this study of administering IM rilpivirine at home. Now, this would be hard to replicate right now for a lot of reasons, but I think does show the potential for offering the IM injections outside of a clinic setting. And this study was led by one of my former co-residents at UW, Eric Meisner, who is now an infectious disease specialist in South Carolina at MUSC. So he did this demonstration project. It was for 12 months, and participants who had already opted to switch clinically, had already opted to switch to IM rilpivirine, were simply given the choice. Do you want to receive your injections in clinic or at home? Meds were obtained through insurance. The administration at home was covered by a study grant. So that is one of the reasons this would be hard to replicate or disseminate broadly. And we do need better coverage and options for administering IM rilpivirine outside of the clinic. But for those who opted to do their injections at home, the drug was delivered to their house. They, of course, had to have refrigeration capabilities, which would not be true for all of our patients. And then an LPN visit was scheduled for each injection. There were 33 individuals who enrolled, 30 have completed the study. For 3, the study is ongoing. And about half and half chose to receive their injections primarily at home or primarily in clinic, which I found interesting. There was no difference in mean days between injections or viral load suppression comparing those who chose primarily at home or primarily in clinic. And I say primarily because there was a little bit of crossover. The individuals who were receiving injections at home had an occasional injection in clinic if it correlated with their provider visit or things like that. There was a little bit of crossover, but overall crossover was infrequent. And it was commented in this presentation that that was a surprise to the researchers, that they thought that everyone who started injections in clinic would then want to do it at home. But that wasn't true. People had a lot of different reasons for either wanting to do it in clinic or at home. But I think the power of this is the potential to give options. And again, I think what we really need is coverage and financial support to be able to arrange things like this. There was also a nice study at CROI of administering IM rilpivirine in an alternative anatomic site, which could be very useful for individuals with gluteal implants or other contraindications to gluteal injections. I'll encourage you to look at this more closely if this is relevant to your work, but basically volunteers who had been in one of the trials receiving IM gluteal injections received 16 weeks of injections in the vastus lateralis. This is a depiction of where the injections were given. And overall, the punchline is people did really well, drug levels were good, viral loads remained suppressed, and really this seemed like a viable option. The FDA package insert has not been updated to support this alternative anatomic site yet, but it is being done in instances where people just cannot receive gluteal injections. The only other thing I would note is when asked which site was preferred, 60% did prefer gluteal injections and cited less pain at that site than in the lateral thigh. And the injections in the gluteal region, I understand, can be quite painful. So there's a suggestion here that injections in the lateral thigh might cause even more pain, but something important to be aware of. I'm going to switch to lenacapavir, and I'm going to ask you a question, and then I'll take a look at the chat. I see at least one question in the chat that I haven't registered yet. I'll digest that in a sec. And Chris, maybe we can pull up this question. I'd like to know how many of your patients or clients are currently receiving lenacapavir, the every 6-month subcutaneous capsid inhibitor, for those of you who weren't with us at the beginning. And I'm now looking at the chat box, digesting questions. Matt, thanks so much for that question. I think it is theoretically absolutely an option. Caboprivrine plus TDF, FTC daily as an oral drug, I think would overcome the minor resistance to cabotegravir or rilpivirine. I think that the challenge would be the adherence to the daily oral drug, but upfront until a person were suppressed, and then maybe after some time pulling off the oral therapy, I think could be theoretically effective. That said, as I'll show you in the lenacapavir trials, when a long-acting agent is combined with daily oral ART, if there are missed doses of the daily oral ART, resistance can absolutely emerge. So I think for me, that would be a case-by-case basis. And if it seemed like that were the best option for someone after comparing all of our potential HIV treatments, I would absolutely support it. I appreciate the question very much. Chris, why don't we go ahead and end the poll and share the results? So 83% with 0 on lenacapavir, not surprised. Again, it's been difficult to access. 15% with 1 or 2, 2%, one person even with 3 or more people on lenacapavir. Thank you very much for that. Appreciate it. I really appreciate hearing the updates. If you have any input or comments on what it took to obtain the lenacapavir, please share in the chat box. I'd love to learn from you. Let's talk about lenacapavir. Just glancing at the time. Again, this is a long-acting injectable drug with a novel mechanism of action. I want to emphasize that this drug works at multiple times in the HIV life cycle. It works both early and late, both pre-reverse transcription, pre-integration, and post-reverse transcription and integration. So the capsid is this sort of conical shell or house, protein-based house that contains all of the viral transcription mechanism, the viral genome. And this capsid is important for both entry into the nucleus, then it must be disassembled, and reverse transcription is sort of happening during this whole process. The capsid must be disassembled to release the viral DNA, then it gets integrated, and then the capsid becomes important later in the life cycle as well when the virions are being reassembled. So lenacapavir sort of gets in and stiffens the binding between these proteins and makes this capsid so stiff that it becomes really hard to get through into the nucleus. Disassembly is inhibited, and reassembly later in the life cycle is also prevented. So again, it works both early and late. I mentioned this last year, I'll mention it again, but look at David Spock's excellent talk to get into more detail about the mechanism here. David describes this just in such an expert way. I'd encourage you to look at that talk. Now, it's an exciting drug because it has a novel mechanism, because of its long half-life that offers potential for daily or weekly oral dosing, or of course, the every 6-month subcutaneous dosing. So I'll turn to updates. The treatment trials are Capella for individuals with heavy treatment experience, or Calibrate for as initial therapy for treatment naive individuals. And this is a treatment talk, but I will just remind you of the PrEP trials as well, including the one with a comparison to TAF-FTC, which will give us data for TAF-FTC for cisgender women. Now, you probably know that there was an FDA hold for vial incompatibility reasons. not because of concern about lenacapavir as a drug, but because of concerns about the compatibility with the storage container. That was resolved. And this drug was approved just after ACC last year. So let me give you a couple of updates. The Capella trial, which led to the current FDA indication of part of treatment for individuals with heavy ARV experience and drug resistance and few remaining options, was published in the New England Journal 2022. And in this trial, individuals who were age 12 and above had virologic failure on their current regimen, a viral load above 400, and resistance to at least 2 agents from at least 3 of 4 main classes with less than or equal to 2 predicted active agents, entered either a randomized cohort or a non-randomized cohort. Which cohort they entered depended on their change in viral load from screening to randomization. And you can see here was a relatively small study, but those in the randomized cohort got either oral lenacapavir for 14 days plus their failing regimen, or placebo for 14 days plus their failing regimen, offering a comparison of lenacapavir to placebo. And then everyone transitioned to subcutaneous lenacapavir every 6 months plus an optimized background regimen. You can see in the non-randomized cohort, it was lenacapavir as a 14-day load with the optimized background regimen, and then every 6 months plus the optimized background regimen. Optimized background therapy means the most active combination of other drugs available. At the bottom, I've put what the 14 days of oral lenacapavir looked like. It was actually dosing on day 1, then 2, then 8. So it did not involve taking pills every day, but that is one option for initiating lenacapavir. And then you can see what the subcutaneous dosing was. It's a funny dose, 927 milligrams, which requires 2 1.5 milliliter subcutaneous injections in the abdomen. And you can see here the baseline characteristics. This study was sort of praised, lauded for being more inclusive than most. Again, adolescents were allowed into the trial, though as far as I could tell, none actually enrolled. There was enrollment of more Black and Hispanic individuals than a lot of trials have included in the past. There was a really nice editorial in the New England Journal from Jeannie Marazzo that sort of commented on this study and not only the efficacy, but the study design and the participant characteristics. So I encourage you to look at that paper from Jeannie. And you can see here the median viral load, CD4 count, and the number of fully active agents in the optimized background regimen, which was spread from 0 to 1 to 2 or more. Here is the efficacy data at 26 weeks that was published in the New England Journal. You can see here the overall achievement of a viral load below 50. And in all, capsid resistance-associated mutations developed in 8 participants, 4 in each cohort during the maintenance period. If you're someone who tracks the most common resistance mutations for these new drugs, M66I was the most frequent and seems to be the most common mutation that occurs. Now, we saw at CROI last year the virologic efficacy at 52 weeks. And what I really want to note here is that while numbers are small, the efficacy really depended on the amount of active agents in the optimized background regimen. So lenacapavir plus optimized background therapy with no active agents was not nearly as effective. And then what we saw just recently at ID Week were updates from this trial, which was extended from 52 to 104 weeks. So basically at 2 years, you can see here the virologic efficacy. But I think what's even more important here is the resistance that developed. So these are the resistance-associated mutations. I've put, these first 3 are the most frequent resistance mutations to develop with virologic failure on lenacapavir. There were 14 instances of lenacapavir resistance that developed. But what's really important to note here, in all 14 of those cases, there was either 0 fully active agents in the optimized background regimen or documented in adherence to the optimized background therapy. So again, missed doses of the oral therapy that has to be paired with lenacapavir can lead to resistance. But then, and I think this is fascinating, half of those individuals who developed virologic failure and lenacapavir resistance resuppressed while staying on lenacapavir. So it seems that lenacapavir resistance absolutely can happen. It seems that that resistance comes at a cost to the virus. There's a virologic fitness. There's a decrease in virologic fitness of the virus, akin to what happens with a 184V. And similar to the situation of the 184V, there may be benefit to staying on lenacapavir even when resistance has emerged. Now, this was a presentation at ID Week, not fully published. They did not go into how they chose whether or not to continue lenacapavir after resistance emerged, and I hope that's something we hear about more in the future. Let me also remind you about the way that lenacapavir is being studied as part of initial therapy. We did not see any updates on this trial as far as I could tell in conferences since I spoke to you last, but I anticipate we will at CROI in March. So this study is called Calibrate. This is a phase 2 randomized open label trial for treatment naive individuals. And you can see here the randomization arms, lenacapavir sub-Q after the loading doses plus TAF-FTC for both of these arms, transitioning if viral load suppresses to len sub-Q every 6 months plus TAF PO daily, or plus bictegravir PO daily, as compared to an arm that gets len PO daily plus TAF-FTC daily, or what I would call standard of care therapy, bic TAF-FTC daily. Here is the virologic efficacy of those arms, which is quite similar, with again a note that virologic failure occurred. It often occurred, or generally occurred, with missed doses of the oral therapy that was combined with the every 6 month subcutaneous lenacapavir, and it did in 2 cases lead to capsid resistance or lenacapavir resistance associated mutations. These cases are interesting. This one occurred quite early, and it seemed like the 184V occurred first before the capsid resistance mutation. So this person was in this arm and developed virologic failure with resistance in this phase of therapy with lenacapavir sub-Q plus TAF-FTC daily and was missing doses of the TAF-FTC. And then this individual developed capsid resistance only later in therapy, but they were also in the arm that combined lenacapavir with TAF-FTC. So, glancing at the time, other updates on lenacapavir that we saw over the past year at ID Week. We saw a study looking at alternative anatomic sites for the subcutaneous injections. And the message is that injections in the thigh, upper arm, or gluteal region worked just as well and maintained adequate drug levels. At IAS in the summer, we saw that those individuals who had to stop subcutaneous lenacapavir during the FDA clinical hold did fine when they were maintained on weekly oral lenacapavir as a bridge or as a holding mechanism waiting for the FDA to lift the hold. Weekly oral lenacapavir is not approved by the FDA yet, but maybe in the future and may be used as a bridge if someone has to miss their subcutaneous dose. And then at ID Week, Princey Kumar presented this data that weight and BMI change was no different after 80 weeks when comparing the different arms of treatment-naive individuals in the Calibrate study. A couple of reminders from the package insert. If you're considering lenacapavir, there are 2 different initiation options, which you can see here. Each dose does require 2 subcutaneous injections. There are recommendations for repeating the initiation, one of these options, if a dose is missed or delayed. And then I want to emphasize that lenacapavir does have drug-drug interactions. It does have some pretty significant interactions. It is a substrate of CYP3A4, PGP, and UGT1A1, and also a moderate inhibitor of CYP3A4. So if considering this drug, do review for drug-drug interactions, and do remember that residual drug can last in the system for 12 months or more. So the recommendation is to consider drug-drug interactions even if someone stopped this drug and received their last injection more than 12 months ago. Now, I'll turn to lenacapavir. We'll talk about lenacapavir. We'll talk about broadly neutralizing antibodies, and then we'll have a few minutes for questions. So islatravir is a fascinating drug I've mentioned before. I think it's worth knowing about because the clinical trials have resumed, but they have resumed with a lower dose, and I'll show you why. Now, this drug is called an NRTTI. It works really in two different mechanisms that have been described. So it, unlike the NRTIs, which sort of lack this 3' hydroxyl group and compete with other nucleotides and get into the chain and just stop the chain, these actually have the 3' hydroxyl plus another sort of end chain. And so they compete and get in to the elongating new viral DNA, and then may stop the chain by changing the binding site here. But also, if new nucleotides are added and are able to bind here, it changes the structure of the chain such that it becomes so misshapen that replication cannot continue. So slightly different mechanism than the NRTIs, two different mechanisms described, thought that this could be a potent drug active against isolates, even with some pre-existing NRTI resistance like 184V. The K65R seems to even increase susceptibility to this drug. There is potential for daily, weekly, or monthly oral dosing. There was a yearly PrEP implant that made the news that I really can't find out what's happening with that, if anything. And the reason is these concerns that came up that very consistently in the trials, individuals who received this drug experienced decreases in their total lymphocytes and CD4 T cells. And it turns out that the active metabolite causes apoptosis of lymphocytes when it reaches high enough levels. But it seems that that effect is dose dependent, did not lead to an increase in infections or any other clinically concerning outcomes, and seems that the lower doses are safe. This is from a phase 2 study that compared doravirine islatravir to doravirine TDF. In both arms, 3TC was given for the first 24 weeks before dropping to this dual therapy. And you can see here, if we take TDF as a standard of care, you can see the increase in total lymphocytes, increase in CD4 T cells, and increase in B cells. And then this was a dose finding study, and you can see the effect of various doses of islatravir, with the important thing to note being that the higher the dose, the more that improvements in lymphocytes, T cells, and B cells was suppressed. And importantly, the 0.25 milligram daily dose did not seem to have a deleterious impact on these parameters. So what happened was, in most of the phase 3 studies, 0.75 milligrams daily was used, and they saw these bad effects. So now what's going to happen, as I'll show you, is these studies, these phase 3 studies, will be repeated, but all with 0.25 milligrams. So we are going to see more about this study in the future. Again, the changes in lymphocytes and CD4 T cell count and B cell count were dose dependent, reversible, and not associated with increased infections. I think what is unclear is how potent and how effective this drug will remain as we decrease the dose. And I'm reminded of rilpivirine. We were so excited about rilpivirine when it was being developed. It was this novel NNRTI. It was supposed to be potent, well tolerated. And then in the development, it was prolonging the QTC. And so the dose was cut down and down and down. And then once we got rilpivirine approved and available, it just wasn't as potent as other therapy, and resistance developed fairly readily. So will that happen with islatravir? I think time will tell. It is predicted that 0.25 milligrams will be virologically effective and may be active against the 184V mutation, but we will have to see. I'm going to show you an example of what came out of one of the phase 3 studies using the higher dose, the 0.75 milligram dose. So this was a study that compared doravirine islatravir, so 2-drug oral combination therapy, to our standard of care, Big-TAF FTC, for treatment-naive individuals. This was presented at IAS over the summer. You can see here that the 2-drug option was just as effective as Big-TAF FTC. Oh, sorry. And then you can see here what happened with the protocol-defined virologic failures. There was one virologic failure in the doravirine/islatravir arm that occurred at week 24. What was seen was that the virologic response was incomplete, so this individual never suppressed, and you can see that treatment emergent resistance did occur. It is unclear if the 184I predated the doravirine/islatravir therapy or emerged while on islatravir, but the point is that resistance to these drugs can occur. Phenotypically, there was doravirine resistance, though not islatravir resistance. So I think we need to learn more about what predicts islatravir failure and what happens with failure on the drug. And then importantly, with Big TAF FTC, even in cases of virologic rebound or incomplete virologic response, there was no genotypic or phenotypic resistance. And it is very consistent with what we see in clinic, is that if a person misses doses of Big TAF FTC, the viral load can rebound, but we tend not to see development of new resistance, which is one of the benefits of the integrase inhibitors like bictegravir or dolutegravir. We also saw studies presented that showed that the mean change in weight, again, this is a very hot topic of interest, with doravirine/islatravir was not different to the change with Big TAF FTC. And then at IAS, Grace McComsey presented a composite of the switch studies to doravirine/islatravir, and the weight and body composition changes were similar with doravirine/islatravir compared to continuing other ART regimens, with the exception of if someone switched off of TDF or switched off of efavirenz. Both of these are weight suppressing. The switching off those drugs tend to lead to a gain in weight. Again, the pre-switch regimen is very predictive of weight change post-switch. So stay tuned for more on islatravir. These are the phase 3 studies, phase 2 or 3 studies that I can find launched or active in 2023. So a study of as initial ART and then the switch studies. But again, the key here is that it's a lower dose. It's 0.25 milligrams daily, as opposed to 0.75 that was used in the prior studies, or this switch study that is looking at weekly oral lenacapavir/islatravir compared to daily oral Big TAF FTC. So lots more to come on this drug. Development has resumed, and we will see more in the future. And as I mentioned at the beginning, combo doravirine/islatravir and lenacapavir bictegravir have been described as the last new daily oral options for HIV treatment in the pipeline. I guess time will tell if that is true. Let me finish on broadly neutralizing antibodies and then take about 5 minutes for questions. So we haven't talked about these before, but there were a few studies, so I just wanted to mention them. These are exciting for prevention or treatment because they target conserved epitopes of the envelope protein on HIV, so they cover and treat and may be effective against multiple viral strains. Even if the virus is mutating, the thought is that this is a more conserved part of the virus and these may remain effective, though the reality is not everyone is susceptible to these, as I'll show you, and they do have potential alone or in combination with ART or with other immune active therapy. This is a nice diagram of some of the targets on the envelope protein, and I'll show you a study that combined one of these drugs with one of these drugs, 2 bNAbs with 2 different envelope targets along with lenacapavir. So Joe Aron and colleagues presented this at CROI, and really the question here was, can a treatment with 2 broadly neutralizing antibodies plus lenacapavir maintain viral suppression for 6 months? So this has potential to be a treatment given once every 6 months. 20 participants enrolled, but only 45% of people screened were susceptible to both bNAbs. 90% were susceptible to at least one of them, but only 45% were susceptible to both. The blinding was to the bNAb dose, and 18 out of 20 suppressed by week 26. They had plans to do a subsequent infusion and go out to 52 weeks, but then the FDA clinical hold of lenacapavir happened and they had to stop and transition everyone back to oral ART. But basically, lenacapavir plus these 2 broadly neutralizing antibodies given once did maintain suppression for 6 months for 90% of people in both arms. 1 person in the higher dose arm withdrew after week 12 for personal reasons, and there was 1 low-level virologic rebound in this lower dose arm. And it was unclear what happened. There was no genotypic or phenotypic resistance to the drugs, and they resuppressed on their baseline regimen. This is going into phase 2, so I wanted to mention it. And there's another BNAB out there that's getting further in development, so I wanted to bring it up. But then as a last part, I've told you about a lot of things. We've talked about studies of making current treatments more available. We've talked about studies trying to identify simplest oral options with the fewest long-term side effects. We've talked about developing new long-acting agents. Where do you want to see the field go? Where do you think the biggest investment should be placed? I'm curious. The no right answer here. Would just like your opinions. Something else too. I mean, if you come up with something else, I'd love to hear in the chat box what something else is. Where do you think the most significant investment should be placed for future of HIV treatment? And then a couple minutes for questions, comments. Yeah, and I love the something else answer. And I'll ask if you put in something else to type it in the chat box so I know what something else is. And Chris, maybe we give that 3 more seconds. All right, so majority make current treatment options more accessible, followed by develop new long-acting agents, then identify simplest oral options with fewest long-term side effects. 2 votes for something else. I'd love to hear what that is if you're willing to put it in the chat box. Let me close the poll box. And thank you all for your time and attention. It's always an honor to be invited here. I hope that was interesting and had something for you, and happy to take questions. And thanks very much. Easier access to long-acting agents, absolutely.
Thanks, Brian. I see a lot of virtual applause and thumbs up for your excellent overview. And it looks like there are a couple of people that have raised their hands. You want to put your question in the Q&A or the chat?
Yeah, happy to take questions. Shrisha, I'm seeing the chat at the moment. I'm not finding the Q&A box. If you can help me watch the Q&A, that'd be
doesn't
great.
have anything. I think people are putting it in the chat, but Matt just asked, or just put something in the chat.
Yeah, from Matt. Matt, your comments are much appreciated. Matt says, I wrote something else. It depends here if you're interested in new investments in drugs or how we use drugs. I would spend less on high cost drugs and more on housing that has a greater potential to improve health, including viral suppression. Matt, point absolutely well taken and much appreciated.
Yeah, I think just to that point, we have all of these really amazing drugs that could really decrease pill burden and get to patients who have had barriers to taking oral medications and adherence. But right now, as people pointed out, the overwhelming thing is really operational issues around this. And it's great to hear about innovative models where people are bringing drug to people, but how do we fund that sort of thing for a smaller group of patients who would really potentially benefit without those supplemental grants? Is there, how do we weave that into our existing work? And that's the challenge, because I think we all identify that for a small subset of patients, these are potentially really powerful tools in getting to end the epidemic. It's just, how do we make that happen? How do we get that to the people who need it?
Thank you, Shrisha, for putting that into words. I think that was an overarching thought as I put this together, is there are these novel projects, implementation programs, drugs, but if we can't get them to all the people who need them, their capacity to change the epidemic on a big scale is going to be incredibly limited. So really appreciate you putting that into words.
Well, we're at the hour, and I just want to thank you again, Brian. I hope you continue to do this yearly, because it's really helpful to hear about all the new medications, and then even older medications and new uses and things coming in the pipeline. So thank you again so much. And thank you, everyone. Enjoy the rest of your day.
Thanks, everyone.